Good morning, good afternoon, and good evening. I'm Mukta Sandhu, Senior Scientific Education Manager representing Geistlich Pharma, Switzerland. I'm particularly excited for today's webinar, as for this webinar, we do not have just one but two speakers. Professor Ronald Jung, Ronnie Jung, which he's famously known as, and Dr. Anina Zurcher. First things first, a brief introduction. Professor Ronnie Jung is trained in prosthodontics, implant therapy, and oral surgery. He is the chairman and the director of Clinic of Reconstructive Dentistry at the University of Zurich. He is an accomplished and internationally renowned lecturer and researcher, best known for his work in field of hard and soft tissue management and his research on new technologies in implant dentistry. And he is an excellent orator, as all of you know. He is currently president of European Association of Osteointegration and member of board of directors of Osteology Foundation. He has taught and mentored many across the globe, and he has mentored Dr. Anina Zurcher, who is our second speaker. Dr. Anina Zurcher holds a specialist degree in reconstructive dentistry and holds a master's in oral implantology from University of Zurich. Since 2022, she has been working as a full-time faculty member at the Clinic of Reconstructive Dentistry in Zurich. She is actively involved in the clinics and contributes to the education of both undergraduate and postgraduate students and participates in various research projects. So before I hand over to our speakers, few tips to make this webinar very interesting and interactive. Please write down your questions in the question sections and we will address them at the end of the webinar. If you have any technical difficulties, also write to us and my colleague Artem Raskotal will guide you through. Also, before or during our question and answer session, a QR code will be displayed, which will allow you to avail the special offer that is a free trial of our Geistlich Mind Guide online curriculum, which is relevant to this webinar topic. So thank you very much for being with us, Professor Jung and Dr. Zurcher, and the stage is all yours.
So thank you, Mukta, very much for this very kind introduction. And dear friends, dear colleagues all over the world, I would like to welcome you here to this webinar. And for me, it's a very special webinar because I'm doing it together with my dear colleague, Anina Zurcher. We work together in the same department, and she's really representing the young generation of this regeneration format. And we have chosen a topic which I think both is a very dominant topic within our daily life, because we're dealing a lot with clinical cases where people are asking either for a nice aesthetic result or the aesthetic result has not been pleasing, and we are now in the way that we need to improve it. So we would like to look at this topic from a regenerative point of view, but in a way that you can get clear information how you can improve your aesthetic results in implant dentistry. Now, this is what we are doing in our clinical practice. We are at the University of Zurich, and we are dealing with a lot of complex cases related to aesthetic dentistry. And I think we all have to deal with a variety of challenges. I think, Anina, you have also here a challenge.
Yes, absolutely. I mean, we started with how, but I guess we should start with the why. And I remember a case at the very beginning when I started here, and it was a young patient, and it could be not difficult. I mean, from an aesthetical point of view, you have everything you wish for. And I remember she told me when she was 14 years old, she had an accident. She was rollerblading, and she already knew that she's gonna lose one tooth in the upper jaw. So she was a bit worried, and I remember we did it with Professor Jung together with Ronnie, and let's have a look how it went.
So this is obviously one of the super challenging cases, and especially when it's these single tooth anterior cases, it's something which the patient, when we say they have high expectations, actually not true. It's more like they just want to have it as it was before. For us, this is just high expectation. But I would like to look now back. I'm representing now the older generation, and I would like to share with you, Anina, a case which I did more than 23 years ago, a case where I was a postgraduate student, which was also a center in size, similar as your case there. And this is now the clinical situation at the time of implant placement. Now, when you look at the defect morphology, Anina, do you think this is a complex or kind of a very tolerant type of defect?
Well, I mean, I see already the defect buccally, and I mean, from my standpoint, I guess it's kind of a more difficult case, more complex, because you have different aspects to consider.
Yes, I think we do have kind of an extractor socket, we have a buccal dehiscence, but the good thing about this defect is that it's completely inside the bony envelope. Having the implant really inside there, having a nice prominence there, that's kind of a very favorable defect to regenerate, because we have all walls to take into account where we have the regeneration potential from. So this is for sure, it is a multiple aspect, but I would consider this as a very good anterior defect because we are really inside the bony envelope. So what I did at that time point is I regenerated that case. We usually use autogenous bone to place it on the surface of the implant, and then placing the Bio-Oss granules around it, and typically over contour there, knowing that we're going to lose a little bit of volume. So that's what I did, and I think we got a really nice over contour, trying to mimic the root form of the buccal aspect. And then an important part is to close the flap, to have really that we don't have any tension on the flap, and there we use then different types of suture. So on the left, we see the situation just immediately after suturing, and on the right side, that's the situation, how it looks like 4 months later. And when I look at this, I was really disappointed. Look at that, how amazing I could create that contour at the time of implant placement, and then 4 months later, it seems to be everything is gone. Now, this is something which has really been triggering me a lot, and this has also been motivating me to better understand why we have such a reduced contour. And I'm sure everybody in here which does clinical case like this has experienced this type of situation. And for me, the question is then, how can I better maintain the buccal bone contour, or how can I better predictable build up the buccal contour, that what I do at the time of surgery, that I can also maintain these over time to really provide the patient with a nice contour. And in this context, it's very important to actually also look back, what have we done in the past and how successful these techniques are. And this is now, I think, the longest controlled study comparing different regenerative techniques over 22 to 24 years. And the unique part of this study is that it's not up to 22 years. So the minimum observation time is actually 22 years. And I think that's a very important study for our daily clinical practice. Also, when patients asking us about how should we do this, what is the outcome in the future, that's a study to count about. So what we did there, we looked at different type of defects at that time. And these defects have been divided either to be treated with a resorbable collagen membrane or a non-resorbable EPDFE membrane. We had a total of 39 patients which could come to this last visit after 22 to 24 years. That was a big challenge to get these patients because they have been very old. And a total of 147 implants could be included there. And the interesting part about the study is that we do not just compare two different types of membranes, that we also have one group which there was no need for a TBR. And that's the beauty of that study, because we could really see how an implant behaves over such a long time period within just native bone versus an implant which is augmented with one of these techniques. And then we followed up with a mean observation period of 23.5 years. Now, when we look at the implant survival part there, we can nicely see that we have really here a situation where we have a very flat Kaplan-Meier survival analysis. That's always good to see. So it's a very successful treatment, which we are roughly all about 90% of the 22 to 25 to 24 years. And I think that's very remarkable, because there's hardly any technique worldwide, also in orthopedics, which is so successful as this technique. And the beauty is there is no statistically significant difference between the groups. That means the two membrane groups, the regenerative groups, they behave in the same way as we do it with the implants which have been placed in native bone. When we look at different examples here, we have the 5-year, the 13 years, and then the 23 years, and we can see a very stable marginal bone level over these 23.5 years. But what makes that study kind of even more interesting is the fact that we have been able to do with each of these patients a cone beam CT. Because all these long-term studies, they have just been analyzed on the basis of the clinical procedures and on the two-dimensional X-ray, so looking at the marginal bone levels. But we never knew what's actually on the buccal side. And that's really, for me, surprising that we had to wait so long in order to really see what's going to happen on the buccal aspect. And when we look now here at these 3 groups, and I think this is the most important part of the study, is that number one, we have a very stable buccal bone level. But we can see 1 millimeter above the implant shoulder, we have bone, but it ranges between 0 to 0.1 millimeter. So that means it's very thin. And I guarantee you, Anina, we have for sure built up much more than 0.2 millimeter. And also the ones which have no need for bone augmentation, they had for sure more than 0.2 millimeter buccal aspect. Otherwise, we would have grafted that. So it seems to be that we have very stable results from a soft tissue point of view, from a bony point of view, but the buccal bone thickness seems to be reduced. Now, the conclusion out of this utmost important study is that independent of what we are doing, either a TBR procedure or there is no need for a TBR procedure, we are above roughly about 90%. So the ones without TBR, 93.8, a little bit better, but not statistically significant. And there was no difference between the two groups, the two membrane groups. We have very stable bone levels on all levels, on the buccal, proximal, oral part. And clinically, again, there was no difference between the resorbable collagen membrane and the non-resorbable membranes. That was also important because in the past, at that time point when we did that, we always thought that going with a non-resorbable membrane is superior to the collagen membrane, and now over the long-term result, it doesn't seem to be a difference. And most important, this is that study, Anina, you can take for your patients to say what we are doing on a daily basis is a very safe and predictable therapy over more than 22 years.
So, Ronnie, I'm really happy to see these results, and especially that we see stable bone levels is independent on the years. So whenever, even longer, 20 years, we have stable bone, and you see that on the two-dimensional X-ray. So whenever I see them, I see, okay, I'm fine, I'm happy with that. But I already changed the slide, but there's just 1 or 2 dimension, but when you are looking, and you said it already before, 3-dimensionally, there is a difference, right, Ronnie?
So we are used to look at these two-dimensional X-rays, and that's over every place in the world, that's the same thing. But with this, we get now a little bit more insight about what's really happening on the buccal aspect. And now we would like to look a little bit closer to this buccal aspect and how can it be in terms of missing that part. And this is a study which created a lot of noise in 2012. It has been performed by Goran Benic, also a co-worker from the University of Zurich, where he was a scholar at Harvard with Professor H.P. Weber, and he re-evaluated cases which have been treated at Harvard 7 years down the road. And he recalled this patient and did a cone beam CT. And additionally, he placed flowable composite at the outside to better visualize the bone at the soft tissue level, so to have a relation between the bone and soft tissue level. So he analyzed that, and there was a big surprise. Number one is that in 70% of the cases, he could see a buccal bone plate, and he could see a stable soft tissue level. But then in 30% of the cases, he couldn't see a buccal bone plate, not knowing whether it's really missing or whether the cone beam CT was not able to really detect maybe a thin layer of bone there. But the soft tissue level is also fine there. So that was really a shock to see there is very little or no bone there, but with a healthy soft tissue situation. And this at the end stimulated then different groups, research groups. And this was one is in Bern by Danny Buser, and one was here in Zurich, where we looked at how our implants look like after 5 to 9 years in Danny Buser's study. So we also did then cone beam CT, and we have been really motivated after this study by Goran Benic from Boston. Now here we have been very happy to see that we have stable bone levels over 5 to 9 years, with almost no cases with no bone. But you can also see there is much more volume at that aspect. Now the question is, why is that the case?
So, Ronnie, I understood you correctly, right? So whenever we regenerate inside the buccal bone plate, we can consider about 70% the bone plate will still be there buccally. And even more when we go inside and outside the buccal bone, we have even more, about almost 100%. So, there are numbers, and I asking myself, how predictable is then the GBR technique on the short term, long term?
Yes, that's exactly where we need to work on. And you're correct, right? The study which has been done in Boston, they only grafted inside the extraction socket. And there was a surprise there. The other ones, we added more graft material also on the outside of the buccal bone plate. Now, the question is, how predictable are they? And I think we have here a very nice systematic review, which has been done by our clinic. And I want now to know, Anina, what is the efficiency now of this lateral bone augmentation?
Yes, exactly. And these authors wanted to see the efficacy of lateral bone augmentation performed with the implant placement. And actually what they did was they performed a systematic review. So they were screening clinical studies, publication, and the population was that whenever an implant was placed, they had about 5 millimeter defect buccally, and then they applied the GBR technique, or even they left it spontaneously healing. And then they were looking 6 months after at re-entry to assess then the defect resolution. So how much defect was resolved afterwards, so within the 6 months. And so what they found out was, and they were also comparing the different materials and also the biomaterials, the grafting materials. So what they saw is that for when they saw all the clinical studies for optimal defect reduction, always or more often the studies, they used the membrane and grafting material. And when they were even looking a bit closer, so which kind of materials they were used, so there was not one particular material which was more often than the others, but we can say, or the authors said, that the collagen membrane with the particle-genic bone graft material was the most reported and documented materials for the GBR technique. And now it comes more the most interesting part, I guess, because they were then really looking, okay, how successful is then the lateral bone augmentation? And they were saying, okay, about 80% at 6 months, the defect was resolved. But there was also a huge broad range, because you had about 50 to almost 100% in between. So when you are lucky, then you belong to the 100%. But when you're not that lucky, so you're having maybe just 50% defect, which was or is resolved. So just summarize it. When it comes to regeneration of the buccal bone plate, so you have always a biomaterial. I'm not going more in detail. And you have a membrane. And that's the most reported and documented materials. And it's very successful, about 80%. But with a huge range. So let's go a bit deeper to the membranes. And I must say I'm a bit the resorbable membrane type generation, let's say. I'm just saying like that. And, with these membranes, how can I improve then my aesthetic results, really?
Yes, I think you definitely are. And now I think that systematic review was really important to see there is a huge range. Some are really successful, and some with 50%, that's not what we actually want. And you said, when you're lucky, you get the 100%, and not lucky, you're the 50%. So our job is now to provide you, ladies and gentlemen and friends, how can you make yourself really successful and predictable, that it's not about the luck. So when we look at the different types of the membrane, obviously you're more from the collagen type of generation. When I started to do TBR procedure, the non-resolved membranes have been like the gold standard, and then the collagen membrane have been compared to the gold standard. But today, I think that has changed a lot, because we have learned over the last 25 years a lot about the characteristics of the membrane. And we also have understood that besides the effect that I need to have a re-entry surgery to remove the non-resolved membrane, it is much more difficult to handle it from a clinical point of view. They are beautiful in terms of result and predictability, because they really maintain a lot of volume over the time. But we would like really to understand now what are the true differences. And that was then a motivation for a very important study. It was a randomized controlled study, which was initiated by Dave Schneider and then also continued by Nadia Nani, both from our department, where we compared these two membranes in clinical setup in a randomized controlled way, with the aim to better understand the advantages and disadvantages of the two membranes in direct comparison. So we had a total of 39 patients, which have been randomized to either be treated with a collagen membrane or a non-resolvable titanium reinforced membrane. And then all the measurements have been done at the time point of the surgery, including a cone beam CT right after implant placement and bone regeneration. And then after 6 months, we did a re-entry surgery, again, including a cone beam CT thereafter. So when we look at the results after 6 months, we can see that for the on the left-hand side, we have the resolvable membranes. On the right-hand side, we have the non-resolved membranes. And in green, it's the bone volume, and in orange or pink, we have the soft tissue. And what we can already see on the different levels, so it's level 1, level 0 means the level of the implant shoulder, 1 is minus 1 millimeter below the implant shoulder, and so on. We can see the total number is very similar, a little bit in an advantage for the non-resolved membranes, but it is interesting to see the difference in terms of relation bone, relation soft tissue. What we can see on the resolvable part is that we have less bone on the level of the implant shoulder compared to the resolvable membrane, as we can see it here. But it seems to be that the resolved membranes compensated by a thicker soft tissue. That means we have here then really a thicker soft tissue, which provides then overall a very similar contour for both of these membranes, which was very interesting. So on the level of the bone, yes, the non-resolvable EPDFE membrane with titanium reinforcement provides more bone volume compared to a less stable collagen membrane, but the collagen membrane, due to the very tolerance towards the soft tissue, seems to be very favorable for the soft tissue, giving us more soft tissue volume, as we can see it here, having a similar approach.
So it seems that the soft tissue somehow compensate then for not having the bone there. I mean, for the resorbable group.
Yes.
But the volume seems to stay the same way. And, it's always interesting to see also the long-term data, right? Yes. Because there it gets interesting, isn't it? So
usually that's my choice, but I'm happy that you're not part of that.
So I will take over. No, so the same group, they asked themselves, okay, let's look back, or let's look at 5 years. And actually they did. What you can see here, so the surgery was already performed, and then what they were looking at is between baseline. So whenever the patient received his implant crown, and then they were looking within the next 5 years how it behaves between the two different study groups. And on the top of everything, they did also impressions, and then they could look at the volume. And not surprisingly, but we had almost the same results as even almost the same after 6 months. So they had, when they were compared both groups, the resorbable and the non-resorbable group, so the marginal bone level was more or less stable for both groups, and also the clinical outcomes. And when they were looking at the buccal bone volume or the volume itself, it was also not different. So it seems, even as I said before, the resorbable group loses bone on the buccal side, but when you look then at the volume, it seems to have the same result. As I said, it compensates more for this group.
That's actually very interesting because it is in line with this long 22-24 year study. Also there, we see that they come closer to the end result.
Exactly. So, Ronnie?
Now, for me, it's now the question, when I see now coming a long way from this 24, 25 years with the two types of membrane, today, you're a generation which hardly never uses anymore a non-resorbable membrane. You really belong to the resorbable membrane type of generation. And in your clinic, you hardly ever use it anymore. And one of the main reasons is the fact that the membrane is very tolerant. It's great towards soft tissue. Frank Schwartz has done a variety of studies showing how highly biocompatible these native collagen membranes are. And the Bio-Gide especially, it's a great membrane to the soft tissue interface. So when you see a case like this, and we have a postgraduate clinic, so we see also people which have done this for not so many times. When you see a dehiscence with a collagen membrane like this, does it make you nervous?
It did. When I saw my first cases, I was really a bit worried because I see the dehiscences, and I'm just asking myself, how will that going to be in a couple of months? Will that heal, or how will it behave?
I think the experience you also had is that also when it looks like this, we can be really very calm and say, yes, this will heal over the next couple of weeks. I would say 3 to 4 weeks, and usually you have a complete closure of the flap. But I can tell you, Anina, when this happens with a non-resorbable membrane, you're going to be screwed, because that will never heal, and it needs a further intervention. Usually you need to erase a flap again and remove the membrane earlier. So this is a completely different story in terms of the clinical consequences. So that means what we would actually like to have is the collagen membrane as our membrane of choice, a native collagen membrane which is very tolerant to the soft tissues. But we have seen that the membrane per se doesn't provide as much stability. And we have now had a lot of studies, which we have long-term documentation with particulated materials, like Smarties. But what we were thinking is, can we improve our aesthetic results when we embed these particles into a more stable material, so making it more volume stable in that way? Then I have best of both worlds. I can take the membrane of my choice because it's very tolerant to the soft tissue, but it's not so stable. But on the other hand, I'm working on more stabilized graft materials. And that means for us moving from particulated graft materials more towards stabilized graft materials. And that was a transition which we did a couple of years ago. And now we are very excited to share these results with you. In a very important study in 2017, there was a study which we did with Jung Myanmar. He was a colleague from Barcelona, where we did a very simple study in pig jaws in terms of volume stability of graft materials. So in this first study, we had a total of 3 different groups, which we used in pig jaws. Group number 1 was using a xenogenic block and a collagen membrane. This is the Bio-Oss block. Group 2 is the Bio-Oss granules with the collagen membrane, the Bio-Gide membrane. And group 3 was then the same materials as in group 2, but in addition, we are tagging the membrane and stabilizing the membrane. So what we did then, we placed these graft materials into these pig jaws, and then when we place the membrane over the graft material, before we close the flap, we have sent the pics to the first cone beam CT. And that volume gives us then the information about our intended volume during the surgery. And then I start to release the flap, do the Bio-Oss releasing, because we have more volume to cover, and then I suture, and then I send the pics again to the cone beam CT. And this is then the situation after flap closure. So that means we have here the three different groups. The block group, which we shaped according to defect size, and then placed the collagen membrane without stabilizing the collagen membrane. So here the graft material stabilized. Then group 2 is the granules and the collagen membrane placed over it. That's the type of treatment most dentists worldwide are going to use on a daily basis, and which we have seen provides excellent result after 24 years. And group 3 is again the granules and the collagen membrane, but additionally we used 2 titanium pins to stabilize it. Now let's look at the results. We see here the before and the after, and the 2 cone beam CTs. And now we want to see what is the difference. And now, ladies and gentlemen, I would like to ask you to fasten your seatbelts, because you're going to be really in shock about the results of this study. Because we can see in the group green, which is the ones which we have the granules and the collagen membrane, the one group which most dentists worldwide are going to use. Just between placing the graft material and flap closure, we lose 43% of the volume, which is crazy. This is almost half of the volume we have augmented there we're going to lose. Before the patient has ever gone home, started to brush his teeth, started to wear his temporary, started to look into the mirror. No, just after flap closure, we already lost 43%. When we stabilize the graft material with a block, we can significantly reduce it to 18%. But still, it's 18%. And what was also interesting to see that the same graft materials, but the membrane is stabilized with pins, we can also significantly reduce it to 19%. But these are really dramatic changes. So this was really an eye-opener for us when it comes to that part. So we concluded that the synergetic graft material in block form can significantly reduce volume loss. You could also see that when we stabilize the membrane with pins, we can reduce the volume loss. And at the end of the day, we need to ask ourselves, why not doing it together?
I mean, really, it seems from a mechanical point of view, you need stabilization. And because I like always to see these in vitro studies, but of course I also want to see the clinic, right?
Sure.
Ronnie.
Now, let's see what have we done in the clinic so far. There is one study which has been published by Goran Benic. He was the project leader there in 2019. And in this randomized controlled study, we used the setup like we have done before, comparing the 2 different membranes. But here we have the same membrane. That means that the one which we like most in terms of being tolerant, the native collagen membrane. And we compared using then the granules with pins and also the block with pins. So here on the right-hand side, we tried to combine both. We want to have a more stable kind of graft material, and we stabilize the collagen membrane. Now, in this study, we included a total of 24 patients, and they got then these 2 different treatments. And the same way as before, they got measurements at the time of surgery, and then immediately after flap closure, we did the first cone beam CT, and after 6 months, we did another re-entry surgery, including a cone beam CT. So these are the 2 groups. We see on the left-hand side, one group which receives the block and the other one which receives granules. And we see we have here 2 cases, lower premolar area, which is not so aesthetic, but they're very challenging. Because you can see here, it is exactly what I meant before. Here you can see there's no supporting walls. The implant is kind of not completely inside the bony envelope. On the block side, it's really sticking out there. And these are the difficult ones, especially also the lower mandible here. You have a flat vestibulum, you have a lot of movements in that area. So they're really difficult to get sufficient volume. So here, on the one hand, they get the granules, And on the left-hand side, we get the block. The block is a little bit difficult to adjust it because it's brittle and you need to cut it according to the shape there. And then the collagen membrane, including the pins, are stabilizing the graft material there. And this is then the re-entry after 6 months, where we can see two different situations. On the left-hand side, the block, where it seems to be very nice amount of bone there, still a lot of volume on the buccal side of the implant shoulder. And this is where I want to have the bone, Anina, because we are both not just surgeons, we also prosthodontist. And as a prosthodontist, when I put my head on as a prosthodontist, I want to have volume at exactly that part, because that provides me the support of the soft tissue. And on the cranial side, you can see it's gone on the level of the implant shoulder. So when we look now at the different measurements, intraoperative, postoperative, and 6 months later between the two groups, we come to the following results. When we measure the situation intraoperatively, in the block group, we have a measurement on the implant shoulder of 3.2 and on the cranial side on 4 millimeters. Now, this was statistically significant. So we get more on the cranial side than on the block side. Do you know why?
Do we tend to just augment more?
Yes, exactly. Because we intuitively know that we will lose more, so we try to put more that we can lose something, and it's still good then afterwards. So we have significantly more now for the granules. Now, we close the flap, like in the pictures. We close the flap in this part, and now we see on the side of the block, there is nothing which has happened there. We are in the same level. Mm-hmm. But on the level of the granules, we lose from 4 millimeter to 2.5. And this is approximately 37%. Before we had this 43%. So again, here, just by flap closure, we lose so much volume. It's crazy.
And it's just depending on us.
Yes, it's just the patient has not done anything to that time point. And then patient goes home and comes back 6 months later. On the side of the block, we can maintain 2.9 millimeter, which is amazing at that part. And on the level of the granules, it drops from 2.5 to 0.2. And now what I love about that is, this is exactly 0.2 millimeter from the study, which we had after 22 to 24 years. So there it seems to be everything takes place within the first 6 months. And then it stays very stable. So from a health point of view, it looks good. But we don't have the volume we actually want. So the conclusion of that study was that the block substitute materials in combination with the collagen membrane are superior in terms of volume stability compared to the ones with the graft material. And it seems to be that a considerable displacement of the graft material takes place. We actually don't know where the graft material is. Mm-hmm. So it just seems to be around. Maybe it is resolved, or we don't know it whether it's really true. And then the block maintains a much better contour after 6 months.
Yeah, I guess it's really a key aspect that we don't know where it goes, even when we overbuild. And yes, that is something which is very interesting. And, I'm asking myself, and now we saw the different groups, and are there any more improvements? Are we going to have, like, on one specific area, even better results with another group?
Yes, but I think we need to see how we further can improve that. And we have now learned about using the block. But the block provides nice results in terms of volume stability, but it's a little bit difficult in terms of handling, because it's brittle and it is really difficult to cut it and bring it into the position. So we were thinking, let's make it easier and even improve it on the level of the soft tissue. And that's how we came with the L-shaped technique, where we're using then the Bio-Oss collagen, which on the buccal side, we have the volume, and it is even put on top of the implant shoulder to maintain the soft tissue volume also in that part, with the idea to potentially avoid then soft tissue grafting in these areas. And here we repeated the same study with Jung Myanmar there, now using the L-shaped technique compared to the granules with the pins. So we have on the one hand the same group as last time, where we have the granules and the collagen membrane, and on the other hand, we had the L-shaped technique. And here, when we did the same procedure also with the cone beam CT before flap closure and after flap closure, we were very surprised about what we have seen here. Because on the one hand, we could see that with the granules, we are here with 20% loss. Last time we lost 19%. That tells us that we had kind of a very reproducible setup that we can do 2 times the study and we come up to the same result. And now with the L shape, we only reduced the volume to 2.4%. So we went from 43% to 2.4%. So this is really a very important finding in that context. So it seems to be that the synthetic graft material with 10% collagen is a good compromise to really improve the volume stability in that area. And it is important to use pins for that part. Now, let's look into the clinical situation. And here is a case which I did more than 15 years ago. We have 2 missing central incisors. We can see here they both had a fracture. And on the right-hand side, we see we have one larger defect at the position of the left central incisor and a smaller defect here. So we placed 2 implants in the correct prosthetic position, seeing here the dehiscence defect. And this has then been augmented the same way as before. We're using a little bit of autogenous bone on top of the implant surface, granules to fill up all the voids, and then using the Bio-Oss collagen, the stabilized graft material, to form this L shape. The best way is to wetten it before, cut it to this L, and then to use per implant 1 L. And this gives us then this extra volume and the extra stability of the contour. And then to flip the membrane over to tack it palatally underneath. And it's important that we have a pin there because it's really like packing it a little bit similar like what Istvan Urban is doing with a sausage technique. And then we close it with different type of sutures. And here's a situation after 1 week before suture removal, where we had a very uneventful healing. The patient did not want to wear a removable dent, so he had a temporary resin bonded bridge. Then after 3 to 6 months, depending on the amount of bone augmentation, we're going to do an abutment connection with this U-form incision, do a scan or an impression. This is an old case. There we didn't have the scans ready, and then placing 2 healing abutments in place. And then we get the temporary reconstruction where we start to condition the soft tissues. They're on the contour at the beginning, and we start to condition the soft tissue in its ideal form, as we can see it here, where we have beautiful result and a very nice stability on the buccal aspect. And then a final individual impression or scan today, and then here having the reconstruction before placing them, and here then the reconstruction in place, where we end up with a very beautiful result. And here, this is the 10-year result, where we still can see a very pleasing result over such a long time period. Now, how about your clinical results, Anina? What is your experience when it comes to these type of cases?
Well, now you put myself on the spotlight. Well, I started with this case at the very beginning, and it's the case where a young patient had a rollerblade accident, and we already said she will lose the 1 tooth in the upper jaw. So it was a similar clinical scenario. So we had also a huge buccal bone defect, which we had to fill up. So what we did, we placed an implant, it was stable, and then we had to augment. And how did we do it? We did it also with the same way as Ronnie already showed in the other clinical scenario. We applied the L-shaped technique. Also here, over contouring was one of the things we had to do. We closed it, and already there, we see over the years, we lose a bit, but it looks really nice. And also there, we did the provisional crown and then the permanent crown, and it looked like that at delivery of the crown. So, Ronnie has always the long-term data, but I don't have it so far. So, I'm always interested in the long-term data of L-shape and other technique, which is, I guess, very important and also interesting to see. And actually, that we did. In a retrospective study, we were looking at all the cases here at our clinic, which were treated in the front area And all the cases, all the patients received a GBR, the L-shaped technique. And of course, we wanted then to see the aesthetic outcome. And the first thing we were looking at was the PES-West score, so the aesthetic score in the front. So we were looking at the soft tissue level and also on the crown level on the white aesthetic area. And what we could see, we were very good. I mean, we had on both sides almost 10, which is the best score you can have. On the one side, we had, I guess, also very good dental technicians, but also when we evaluated the soft tissues, it was really good. And then we went even further. Whenever we had the two models to compare from delivery to the follow-up visit, we also wanted to see how much we gained at a very important area, and mainly at the 1 millimeter below the soft tissue margin. And there we could see even after up to 14 years, we had a gain. It's not bad. And we also asked, of course, the patients, how happy are they? And I guess they were really answering honestly. And we can also say they were really happy.
See, with these 4 cases, it's difficult to see which one is actually the implant case here.
Yes.
So it's always the left center inside there, and I think they're really amazing results over this time period there.
Absolutely. So there I had it, my long-term data, and we can say the L-shaped technique appears to maintain the dimensional stability where the area was augmented. And we also see that it comes with optimal aesthetic outcomes, and of course, the patients were also very happy with the result.
Yes.
So, Ronnie.
So let's come to the conclusion where we would like to come now to what we have learned from this very important part. I think we came from a long journey in terms of the long-term documentation, then what we have learned from this long-term part. And I think what we have clearly seen is that we using a resorbable membrane or a non-resorbable membrane both provide excellent long-term results over a very long time period of 22 to 24 years with no difference to implants which have been placed with no need for GBR. So it's a very safe procedure. We also have seen that increasing the stability of the graft material or stabilizing the collagen membrane with pins has a benefit in terms of volume stability. That when we not just want to have kind of healthy results, we want to have nice aesthetic results, we need to stabilize these materials. And within the preclinical results, we could see that the L-shaped graft material, stabilized material, helps us to provide the volume in a much better way than the way we usually do it.
And also what we could see was when we were comparing two different type of membranes. So actually on the bone level, there were differences seen, but when we were looking at the total volume on both sides, it was similar. And then later on, we were also looking at the systematic review where we could nicely see that whenever we do lateral bone augmentation, we will see a mean defect resolution of about 80%. But we have to note that there is a broad range in between. And then when we were looking at our L-shaped technique, also there it appears that this technique maintained the dimensional stability over the years. I mean, we had almost 14 years of follow-up.
Yes, so with this, I think we would like to thank you very much for your kind attention. I think it's a very exciting topic. It was exciting for Anina and myself, but we are here just among others. So we represent the entire team here of the University of Zurich, which we are very thankful for working with such a great team. And we do come to work every day with so much pleasure. And I hope you also enjoyed this webinar. And I'd like to thank you very much for your kind attention.